Well, good morning, everybody. Thank you very much for making the time out of very busy emergency department setting for us to quickly have a look at what's happening with workplace-based assessment. So I'm Dr. Madeleine Muller. For those of you that don't know me, I'm a family physician at Cecilia Makiwane Hospital here in East London. But my main sort of reason why I'm involved in this is that there is a countrywide project, which I'm going to tell you about today, called the WBA Opworx research project that's specifically looking at the implementation of workplace-based assessment within postgraduate training in South Africa. And the project is happening at all 9 universities, and I'm the principal investigator for Walter Sisulu University. So I'm actually helping to support, and we're partly basically learning in terms of how is it going with setting up WBA as part of registrar trainings at WSU, and that cuts across all the disciplines. So today I'm going to cover stuff I normally cover, but I will give it a little bit of a focus in terms of emergency medicine and the surgical disciplines specifically. So this is basically what we're going to be looking. I'm going to look a little bit about why everybody's getting all excited about WBA, and then we will run through actual terminology. What do I mean by WBA? What is all these EPAs all about? What are the clinical competency committees you guys are going to be setting up? I'm going to look at what the tools are that we are planning to use and what tools are already in play. And we'll learn a little bit from you guys what you may or already have been exposed to. And I'm hoping we've got time where I just want to do 2 or 3 slides around feedback, because feedback is one of the core activities as part of WBA. WBA does not work or exist without feedback. So just to jump into it, and there's an extraordinary amount of evidence, but mostly from overseas, in terms of why WBA is an extraordinary addition to our current postgraduate trainings. So as I've mentioned earlier, WBA is always coupled with feedback. And so when they've looked at work-based assessments in overseas programs, there was definitely improved student performance when they looked at assessments. There was also improved performance at the bedside during formative assessments. And there's definitely a positive impact on learning and work performance. But also, interestingly, there's improved work satisfaction. And that's not only from the side of actually working, for example, in your particular setting, but as a learner and a worker, or as a supervisor and a worker. So it's more satisfying for registrars to be doing WBA as part of their work, and it's more satisfying for clinical supervisors to be doing WBA as part of their work than the traditional postgraduate trainings that we've been doing. But I think the reason why everybody's getting so excited about it, and that's partly also been very much driven by community and society, is that WBA enhances patient safety. We can create safer doctors, and there's been specific studies looking, for example, at surgical performance, which have shown that there's actually really less perioperative errors if we're using WBA as one of our training methodologies. And then the other thing is what we talk about our registrar risks. So traditionally, and I'm talking now a little bit from family medicine and some of the disciplines I've already spoken to, you have this 4-year training, your registrars are very busy on the ground doing all this stuff. And then you get to the end of the 4 years and they've got some logbook that the HOD signs off, and then they go off and they do this exams and then they fail. And in the ideal world, we want to be able, by the time you signing a registrar off to go and write those final exams, you actually want to be confident that this guy is ready to be a consultant, and we should expect them to fly through those exams. You should be able to say, no, this guy is definitely there. And yet we know we've got a registrars who get through their 4 years, and then you're suddenly having somebody who's struggling to actually complete or finish, or never end up finishing their MEd. And we want to be able to actually identify registrars that are struggling early. And I think the challenges with it is that you might also have a registrar that's quite good in one particular thing, quite good on what is happening on the floor, but there's actually other areas that he's got major gaps in, and that's not always easy to see. So the idea with the WBAs is that you can have lots of data points and opportunity for feedback from very early on in the training, which gives you the possibility to start picking up if there's problems earlier on and start intervening earlier on before they go off for their big summative assessments. So this is the history of what's happening in South Africa in terms of work-based assessment. So overseas, there's been a lot of stuff, very exciting. And then in March of 2022, so that's almost 3 years ago now, the colleges of medical deans, so the committee of medical deans, so these are the deans from the 9 universities, together with the colleges of medicine, actually decided, okay, we're going to do WBA in South Africa as part of our registrar trainings. This makes sense. We need to upgrade and get into the 21st century. And then October 2022, I'll give very brief feedback on that. They actually did a situational analysis where they sent out surveys to all the disciplines and universities to get an idea of what people thought about this and if we were ready to do such a crazy thing. And then in March 2023, they started running workshops at all the faculties. And I think all the faculties have now been covered in explaining things like EPAs, which is our curriculum basis for doing WBA. And then in September from last year, 2023, this Opworx project that I mentioned was launched at all the different universities to be able to actually see what's happening on the ground as we're implementing. We've got an ethics approval at all the different sites, as well as at WSU. And then we actually now in June 2024, we had a report back from all the provinces on where everybody is. And actually, we're slightly all ahead of the curve, which has been quite good. So actually, the implementation has been going really well, and there's been a lot of enthusiasm of it on the ground. And the idea is that by next year, 2025, we actually want to create a first sort of guideline, a national guideline on WBA and what that needs to look like. So just the situation analysis. So this was done in May 2022. We've had some actual, from the Department of Higher Education, we've actually had some money to do this. And this was this big online survey with about 166 people who filled it in. And I'm just going to focus on some of the barriers and opportunities that was identified in that survey. So I think some of the worries there is around, if we're going to do lots of workplace-based assessments, we need to be able to capture those assessments. And for that, we're going to need e-portfolios. There's no ways you can do this manually. There's always a worry, and we'll talk a little bit about that, around the current organizational culture. And we still have a culture in some departments, not all, where there's sort of a particular way of dealing with training, and that there can be a bit of favoritism. We still see victimization happening in some settings, and there's concern because it can be quite subjective having these one-to-one assessments. We're obviously concerned that our supervisors haven't been trained. I'll talk about that as well. And there's always concerns of, do we have enough resources in infrastructure? But actually, that's been a concern for postgraduate training in general. And then standardization always comes up, and I will talk a little bit about that as well, because of course there's going to be a million different ways of doing WBA in all these different places. So some of the enablers that was noted in that same study is that South Africa is already in a very good, strong regulatory environment in terms of having this agreement with the colleges of medicine. So all of our exams happen through a central body, which is very well set up. And that's actually going to help us in terms of regulating this particular program. Technology is actually also an enabler. Everybody's got a smartphone these days, especially in terms of registrars and clinical supervisors, and we can use that. And everybody's actually already doing WBA. So we're already assessing, although informally, our registrars as we go along. And so it shouldn't be too much of a culture shift. We do also find that most people, once they understand what it's all about, is quite keen. And the registrar is very, very keen on this, which definitely helps. And interestingly, although standardization was brought up as a barrier, we actually think this kind of system is actually going to also improve standardization. And I'll talk more about that a bit later as well. And of course, we will be setting up supervisor trainers. And I'm happy to announce, I'll tell you at the end, that the first college-approved CMSA-approved clinical supervisor training is going to be piloted at WSU next month for people who are keen. So let's just look at this Opworx project that I've mentioned. So this is a national project. Don't worry about reading all the words, but you can see it's a multi-center study. And we're going to look at the current WBA practices in registrar trainings across the country. And the objectives, as you can see, it's still very much looking at the experiences, perceptions, and concerns. So it's not yet looking about how well it's working. It's still actually looking, can WBA work? And the way the study is happening is across the 10 institutions. And the idea was that each institution will choose about 3 disciplines, which we're calling the pilot sites, but actually a lot more people have been piling in. So in Walter Sisulu, for example, we've got 3 pilot sites initially that we identified in 2023. So family medicine, anesthetics, and ops and gynae. But the reason why I'm telling to you guys today is that emergency medicine is quite keen to become part of this. Pediatric surgery, Dr. Titness and them are very keen, and orthopedics has also shown interest. And the idea is that these are all sites that already through their own colleges are exploring WBA, and we are just going to be able to help offer some support and insight in how that's going within the WSU context. And I'm the investigator for the WSU side of things. So the actual way the study is going to use, and you guys might not be part of that this year, is that it starts off with a little training intervention, a bit similar to what I'm doing now, explaining to people what WBA is, people who are already doing a little bit of WBA in their own settings. And then this year we've been doing focus group and semi-structured interviews with registrars and consultants from the departments to find out how that's going. So as you guys are implementing a bit of WBA this year, we might organize some focus groups next year to find out what your experiences, perceptions, concerns, and aspirations are. And so we are already in this process, and we've already had our first focus groups with anesthetics and ops and gynae. Each university has its own ethics approval, and we'll probably all publish our own particular findings as well. So let's quickly just look at actual concepts, and apologies for those of you that are very familiar with this already. I'm going to treat it a little bit like a 101 to make sure that we're all on the same page, and also that this can be a resource as you have people joining the department. So let's just define what am I talking about when I'm talking about work-based place assessment. So firstly, that we are going to stay, I'll talk about EPAs in a minute, but we are going to be setting assessment goals that are specific for the workplace. So everybody's very much used to learning objectives that tells you about lists of things you need to know. We're not going to focus so much on lists of things you need to know. We want to focus on what you need to be able to do. And I think that's why the surgical disciplines find this so helpful. The idea is you have a goal. You're going to say, this is what we expect you to be able to do by the time you finish your registrar training. And now we're going to be observing you regularly throughout the 4 years to check how you are doing in terms of those particular activities. So these particular observations, and there's huge debates about whether we should even use the word assessment. Some people saying we should use the word observation, because these are going to be little formative assessments. So I want to teach you how to do your primary survey for in A&E. I'm going to observe you in a particular workplace setting, and then I'm going to give you feedback and say that works great and that you still need to work on. And you're going to have hundreds of these observations throughout the 4 years that will then build up towards your summative assessment. And that's why the feedback is what makes that's like the little magic bit in all of WBA. Because if supervisors gives high quality and timely feedback every single time you observe your registrar, we're going to be able to massively increase their learning towards these assessment goals that we have been setting. So there's always this concern about subjectivity and concerns about, what about this one particular supervisor's point of view? But the magic bit is the fact that there's going to be so many of these assessments. So because you're having multiple low-stake assessments, you're going to have multiple scenarios it's going to be assessed, and it's going to be assessed by multiple assessors. So all of your clinician consultants are going to be assessing this registrar. You're going to be using senior and experienced medical officers to be doing some of these assessments for your registrar, and that gives us the possibility to use concepts such as saturation, triangulation, and aggregation of all these assessments is what ends up giving you a very valid picture of how your registrar is doing. And this is actually where standardization comes in, because standardization is now not about the actual individual assessments, but about the progress of your registrar towards a common goal. So this is the sort of summary of how it all sits together. We're going to set our curriculum with these EPAs. So that is the goals we're going to set and milestones on where we expect you to be with those goals. Lots of little workplace assessment that happens within the workplace over the 4 years. These all get captured in an e-portfolio, and then the decision making is going to happen through something called the clinical competency committees. And I'm going to break all of these up now, and we're going to go through them in a bit more detail. So when we talk about EPAs, we are talking about a new way of building curriculums. I think you guys are already very familiar with EPAs. You're actually a long way you're a long way progressed already as emergency medicine in the country to building EPAs for your curriculum. So the EPA stands for Entrustable Professional Activity. For those of you that don't know what that means, an EPA is a unit of work. It is what you are expected to be able to take responsibility for when you are an emergency medicine consultant. So what's amazing, when you have all your EPAs together, they actually describes your full disciplinary scope. So what do we trust an emergency medicine consultant in this scenario to be able to do once they complete their training? And your knowledge skills, for example, is captured within that, your ability to do. So you can't do a primary survey unless you have theoretical knowledge behind that. And so usually the recommendation is that you pick between 20 to 40 EPAs to define your whole specialty. So family medicine, we have 22 EPAs, for example. And each college is going to be responsible for developing its own disciplines EPAs. So for emergency medicine for the country, SACOM, the deans, together with the College of Emergency Medicine, together they're going to figure out what is the EPAs going to be for emergency medicine. So I'll just show you in a minute what the family medicine one looks like. What's important to realize that nationally you've decided on these are our EPAs, but then each training program. So in PE, for example, at WSU, we would decide these are going to be these are what we expect the registrar to achieve every year. What are the milestones for that particular EPA? So that's just the family medicine ones. And it's just to give you an idea of the concept. You can see we use a verb in each of those ones. You'll see there's no words like good or effective or competent. It's all just, this is the activity, because we expect you to be competent with all of these activities by the time you complete your training. So you see we've got, for example, managing women and newborns. This is family medicine, so very broad. And you can see in our EPA number 13, we have managing patients with emergency conditions. So you will now, and this is what also nice about this is we have to be able to differentiate what's the difference between a family physician working in emergency medicine, and we'll be able to see what is expected of that versus what you will have in terms of what you expect from an emergency medicine consultant. And you will have, of course, 10 or 20 EPAs just describing emergency medicine. So I'm going to show you what it looks like, the details. So for each of these 22, whatever how many EPAs you're going to have, you'll be writing, and I think you're doing that already, detailed specifications for each of yours. And I thought I'll show you what our detailed specifications for emergency conditions look like for family physicians. So you will start off and you have a description and you say, this is what's included. So what is within the scope of practice of a family medicine doctor doing emergency medicine, and what is not particularly within this EPA. Then we also see what's the problem if they don't get this right. But more importantly for you guys is we then include what is the knowledge and skills that we expect them to be able to know. So we've got a list here. That is all the kinds of things that, and this is sort of where your topics start coming in. You can see we've got another list of knowledge and consultation skills. Then we've got a list of procedures that we expect them to be able to do. Then we've got a list of mental health emergency procedures. And then we've got some stuff around attitudes and behaviors. We will also outline what experiences we expect a family medicine to have. So you will have, they expect them during their 4 years. So when you do a detailed one, you will not obviously have one for emergency medicine. You might have one on trauma, will be one of your EPAs. And then you will have how much experience you expect them to have had in that particular area by the time they finish their 4 years. And if there's any particular trainings they need to do. And then very important, you will have the resources that's linked to that particular detailed EPA. This is where it gets interesting. So for each EPA, so let's take an example. You've set trauma, managing patients with trauma as one of your emergency medicine EPAs. Then you're going to say, well, what is the entrustment decisions? And I'll talk about entrustment in a moment. You can think assessment. How am I going to assess that EPA? So what is the kinds of work-based assessments I'm going to do over the 4 years What do I expect from my registrar to complete for trauma? And so, for example, for us, we would do, and I'll show you the tools in the moment. You might go, I want them to have been observed doing so many resusces for trauma resusces, for example. Or I want them to have, they must have so many ICDs, or I don't know. You will decide what kinds of things you want to have had observed as part of your WBA. That sounds a bit confusing. It's going to be easier when we actually look at the tools itself. So now we've got our goals, and now we're going to delve a little bit into the actual workplace-based assessment. So the idea is that you're going to actually formalize something that you're already doing informally. So if you're a consultant and you're on the floor with your registrars in emergency medicine and you decide, okay, I want to take a quick tea break. You got a case that comes in and you're going to make informally, you're going to make a decision on, oh, I think the registrar can manage this case. I'm going to go off for tea or lunch or whatever. Or actually, maybe I'll just think I'll hang around for this one. And that has to do with trust. And it has to do with trust that's specific to how well do I think this registrar can manage this particular kind of a case. And that decision we actually make all the time. Every single time you put somebody on call and you're actually not present, you've made a decision based on a certain amount of trust. So WBA formalizes these little informal decisions that you are making, but also forces you to give feedback. So it creates opportunities where you actually have to watch the registrar doing a particular activity, and then you have to give feedback, which is our power engine. So the idea is that within that, what gives this then validity is that the observation that you're doing is not just going to be an ad hoc observation of, well, I'll just stand here and then say what I think. We are going to use a standardized tool in terms of how you're going to do this observation. We are going to work with reflection, and we're going to actually encourage the registrar to reflect as well. We want registrars to learn how to be able to identify their own gaps. And then within that workplace assessment, we're going to work about how do you create a trusting relationship and giving good feedback. If we get these things right, get a good tool, work with reflection, give good feedback, you actually have a very high level of validity of these work-based place assessments. So with validity, we mean is that if you've got through lots of, say, workplace place assessments, say, this registrar, I can trust to do this thing, that assessment of trust is a very valid reflection of what the registrar is actually able to do. So if you imagine, for example, an OSCE, so for example, you get the registrar to do an OSCE setting, you get him to do an ICD, for example. That has not got as high validity as a workplace assessment, because you still don't know exactly how he would perform when he's actually in a workplace setting. And then to make these reliable is the fact that you have multiple biopsies over time, because you've got lots and lots of these little different assessments. So EPAs is going to be able to help us identify what we need to observe. So because we've written these lovely detailed of all the things we expect them to do over the 4 years, we can now start saying, these are the kinds of things we want to be able to watch. Do you do? And there's lots of opportunities of the kinds of things you can watch. So you can actually watch a consultation, or in your case, an assessment with a patient coming in. And very important, these can be direct. So you sit there and you watch them do something. It also doesn't have to be the whole consultation. You can observe also a part of a consultation or a part of a procedure. But very important is that one can do an awful lot with indirect presentation of consultations, especially on registrar level. And I'll show you the tool for that in a minute, because this happens all the time. We often have a scenario where a registrar might call you up or might come to you and say, listen, can I quickly discuss a patient with you? And we can actually make those into WBAs, which is a lovely opportunity. Obviously, you're going to want procedures observed, so very specific procedures that you actually want to observe in ad hoc. You can also go through their clinical notes. So, for example, if they've done a sexual assault, you can go through their forensic recording of that particular consultation to check how complete or how good or whatever it is, and you can fill in a tool for that. And then in family medicine, we also look at things like presentations and the ability to mentor, journal clubs, all kinds of things. What's lovely with workplace observations is that professional behavior is automatically embedded in that. So if you've got a patient, if you've watched a resus and the patient has passed away, and you watch how he deals with the team, for example, and you watch how he deals with the debrief afterwards, or how they deal with the family afterwards, you can also then observe their ability to be compassionate, their ability to listen, their ability to work in a team. So we're also then able to give feedback on those kinds of qualities within the WBA setting. So to capture all of these, there's lots of different tools, and I'm going to show you some of our favorites in a minute. In terms of standardization, so this is from Vanessa Birch. She calls these a value-laden concept that ignores contextual realities. We cannot standardize. It's impossible to standardize registrar trainings. Even within WSU, the training the registrars will be getting in PE and Mthatha and East London is completely different. And all the encounters are going to be completely different. So this is not, we're not aiming for standardization of the actual observations. What we are benchmarking is our trust of the registrar of being able to perform that EPA safely. And so we are working with entrustment decisions that's working about, because of the way this registrar is performing in my department, I trust them to be able to go forward in managing these particular kinds of patients. And that we can standardize across the country in terms of what are those activities we expect them all to be able to do. So let's look a little bit at the e-portfolio possibilities and tools. So what we're going to be recording at the end of each of these WBAs is something called an entrustable decision. That's a word, by the way, it's not in the dictionary. It's been invented especially for the world of work-based place WBAs. And the idea is that every single time you do a WBA for that particular activity or consultation or topic that you're observing, you're going to decide, okay, now, according to what I've seen, how well do I trust them to be able to do this in the future? So observation only, so I do it and you watch. Level 2 is direct supervision. Level 3, which is where most of our registrars, or almost all my registrars get 3 for almost every single WBA I'm doing at the moment, because they're in their second year, means that was great. I'm happy for them to see patients independently. I'm happy for them to be on call on their own, but they need to have somebody they can call when they're not sure, and there needs to be backup available. So that's that indirect supervision scenario that we're working in with our registrars. 4 is actually usually what we're expecting for them to be by the time they finish as consultants. So we'd be able to do this independently. And therefore we don't need to be in the room, and we can now set them off into the communities to work independently. And then level 5 is actually that you can teach that particular skills to others. So 4 and 5 is your consultant level skills for a particular activity. So what's interesting with trust, as I've mentioned before, is it's forward-looking. So it's not like an assessment where you go, how well did they do in the past? This is the percentage they got for that topic. Trust means that you're making a decision of how well do I think they're going to manage this in the future as well. And as I say, we're actually making those decisions all the time. It's therefore also very much looking at patient safety. Okay, great. I've observed him doing that. Am I happy to let him loose on patients doing this independently in the future? And it's actually based on something that you've seen, not something that you are assuming. And what's very nice about this is that we are including our professional behavior. What's also good with trust is that it makes us be very clear about what the limitations is of what they can or cannot do in the future. And we're moving away from, oh, you're competent or you're not competent in this, rather than saying, well, hold on, I'm quite happy that you're quite good at this, but I think I need to be with you a couple of more times, or I think you need to check with me next time before I'm happy for you to do this independently. This is just fun because it's from the anaesthetists. They've got their own little entrustment levels. They've actually got 8 levels, and they've made them very colloquial. Doing with the operating room is whether you think you can take a brief break, you can take a lunch break. I still have to check in regularly. I can wait till he asks for help. I can just preview everything with the trainee and then let them go off on their own. I don't have to be there at all. And this trainee can work as a consultant. So it's that same concept. So the next concept, now you've got your lovely EPAs that gives you a curriculum. You've got all your little assessments. And now we're going to set milestones. So with milestones, so you can't work on 22 EPAs in every year. That's just crazy. And we do normally within family medicine as well. We would ask the registrars to focus on specific areas of competencies every year. So although they do a bit of everything while they're in their working situations, for example, in our first year, they concentrated on ops and gynae. This year, they actually concentrating on surgery and anesthetics. So you guys will also look, depending on your training program, you will decide, okay, this year we want to set maybe 4 or 6 EPAs. And then you might say at the end of first year, for these particular 6 EPAs, I want them to be at level 3. And for this EPA, actually by their second year, I already want them to be on level 2 or level 4. So you can achieve your EPAs at different times, depending on the kind of EPA. You might also have a medical officer who's been working in emergency medicine forever, and now he's specializing and actually is an absolute whiz at trauma, and you might even already sign him off for that EPA at the end of his first year. So it's not a pass-fail. Every single one is just a progress towards entrustment. And it's not like you count all the assessments and take an average. It's like, okay, you're level 3, you're level 3, you're level 3. Oh, look, you've reached level 4. And then when you leave level 4, now we certify as trust, as sort of the capstone event. We can now trust you to do this activity. So this means we have to capture all these millions of little entrustment decisions. And for that, you need a portfolio. And in e-portfolio is by far the easiest way to do that. And the family medicine guys, we got some funding. So we got a posh one called Scorion. I think it's slightly too posh because we've got way too many forms and we're capturing way too many different things. Where the guys who are using very simple online tools have really, really simplified it. And I'll show you those in a minute. But you can put all of your things in there. So you can have your WBAs in there, but also if you attend a CPD, you can put that in there. If you've gone to do your ATLS or ACLS, that will all be recorded in your e-portfolio. What's nice now is that you've got your EPA. So whenever you have an observation or whenever you if you do your ATLS, then your ATLS is going to be linked to your EPA that was based on, for example, your trauma EPA. Some activities might not obviously need any entrustment decisions like your CPD sessions. And then some of them will have these entrustment decisions that's going to be signed off by a senior doctor. This is to show you what our scoring on dashboard looks like. And then you've got your different supervisors, and then you have like a summary of the feedback. And I'll show you the forms in a moment. And then you have a place to have all your tools together. And then you can actually see over time how they are progressing on their different EPAs. So I thought I'll summarize a little bit some of the tools that's out there. So what's happening is all the different colleges, we're all in the sandbox at the moment, and different people are playing with different things. People's tools are still changing. Even now with family medicine, our tools, we've just sat down with Scorion and we've revised and refined a little bit. And so we'll chat a little bit at the end on whether you guys already have a tools and what your tools look like. But these are some of the tools. Some of you might not know them. I'll show some examples in a minute. We've got something called a mini CEX, which is a tool for observing a consultation that will be relevant in, for example, in some of your accident and emergency settings when you're not actually doing a procedure, but you're just assessing a consultation with a patient. By far, the most common that you're going to use is a DOPS kind of a tool, which is a tool that observes an actual procedure. So the Ops and Gynae ones, it's got a very specific cesarean section one, and there's a very specific anesthetics one as well. So one can also have like tailor-made tools or checklists. What we really like, this is a family medicine invention, and this is the one I use by far the most. It's called Entrustment Decision Tool or Learning Conversation Tool. So this is when my registrars at the moment are all off-site. So they call me every 2 weeks and discuss a patient with me, and they have to present it family medicine style. And then we fill in an entrustment decision tool, and I make an entrustment decision based on that case discussion. So you'll also have in your e-portfolio just your records of things that have been happening. So if they've attended a CPD meeting, if they've attended a supervisor meeting, logbooks. So you might not need to have all the procedures actually observed, because that's nuts. But you might want to have a logbook of, I want them to have done so many of each of these particular procedures. So a logbook can be in that e-portfolio as well. And then your learning plans will be individualized for your registrars depending on where they're at with each of their EPAs. So this is the mini CEX. It's just to show you that they're very generic. So it doesn't matter what consultation you look at, it always is going to just check how good are you taking history, doing a physical examination, making a clinical judgment, how organized you were, et cetera, et cetera. Similarly with the DOPS, you can do this on any procedure. And they've got pre-procedure preparation in there, analgesia, technical ability, aseptic, post-procedure management. So that's quite a nice standard tool. And this is the entrustment-based tool. So the idea is the scenario presents a case like they normally do. And we do train our registrars to present in a very particular way. But then what you do is that you as a consultant then probe to think a little bit laterally than just the case. Okay, so you're presenting a case to me of a drug-induced liver injury. So what would you do if this patient also had kidney failure, for example? Or what would you do if this patient is also HIV positive, for example? So you would sort of probe to try and get an idea on this particular topic that we are discussing. How confident is this registrar, and therefore what level of entrustment will I give him for this particular very small part of the curriculum? So, and then just very important, sorry, before I forget. So for each of these tools, you will always make an entrustment decision. Then you will give feedback, and then there'll be an action plan on where you're going to go forward for that particular thing that you've looked at. What I want to show you next is the tool that's used by Ops and Gynae. So the Ops and Gynae guys have also already set their EPAs, and in family medicine, we have 14 tools. That includes various versions of what I've just shown you. The Ops and Gynae guys have got one tool, and that's it. In KZN, the surgical guys have also developed a single tool that they're just using for the surgical procedures, and they've actually written a very nice paper on the implementation of that tool, which I will send you around as well. And there's a lot of sort of overlaps between all these tools. But it's quite nice to look at this tool because it gives you an idea of what the principle is of the tool that you are going to develop for your particular setting. So you might already have tools, or you're going to be developing a tool. And as I say, at the moment, it's all experimentation. I'm giving you here a picture of what it would look like as a paper copy. But what's part of the Opworx project is that there is the possibility, there is one of the teams has developed a Google Forms type of app that they will set up for your department. You pay them 1,500 Rand a year. And then they will set up like a little mini electronic portfolio on which your registrars will be able to capture all of their WBAs using a single tool. So the Ops and Gynae guys have done that. They've worked together with this team. They've got this little tool, and this at the moment is an electronic tool that can be used. I would recommend in the beginning that one has a paper tool to play with until you're happy with what your tool looks like, and then very quickly look at an electronic way of capturing those. So you can see here, obviously, you have your date of your observation, who's the registrar and who's the person who did it. What they've done in Ops and Gynae is they've identified the type of activities that was observed, and then there's a description. So it's very generic, so you can decide what exactly happened. And then they've got a difficulty rating. So is this type of activity compared to the average type? Was this quite sort of normal, average ICD? Was this a little bit more difficult, or this was a very difficult one, actually? And then you'll have a little description of how the trainee did. So this is just describing on what happened. And then the second part of the form, very simple. Based on that, you're now going to do your level of entrustment. The Ops and Gynae guys have decided not even to give it a number. They just describe them, and it's exactly those 5 levels I talked about earlier. And then the feedback, but very important. So the feedback always looks the same. It doesn't matter which WBA tool you use. First, you're going to talk about one aspect of the activity, at least that was done well. And the idea is to help the registrar identify what they're doing well. And then you're going to give at least one suggestion in terms of what could be done differently or what they can work on for the future. And then the action plan can be able to say stuff like, oh, I need you to go and write this guideline, or please go and watch this video, or I want you to go and practice this particular thing. And this will all then be captured within that logbook. Very easy. So the final concept we need to cover is what's called the Clinical Competency Committee. And so they are the ones that's going to have to help make the decisioning. So the idea is that you don't want to sign off more than 10, probably much less than 10 EPAs, entrustments in a year. So there's going to be 10, for probably 6 or 7 or 8 times per year, EPAs that you're going to look at, that you're going to say at which level of entrustment are they for these particular 6 or 8 EPAs. You're going to use all of those WBAs you've done to help you make that decision. And when somebody gets to a level 4 of that EPA, you're going to give them, look, I don't know who got that, a star, a statement of awarded responsibility, which says, for managing trauma in the emergency unit, I now entrust you to be able to do this independently as a consultant. So that EPA then gets signed off. So the idea is that when you now look at assessment, just to bring us back to what we're doing at the moment, is you're going to have these professional workplaces opinions that's going to happen throughout the 4 years. And then there's still going to be at the end of your summative assessment side, you're still going to have a written assessment of the knowledge components of your particular discipline. And you might still decide if there needs to be specific orals or OSCEs that are relevant for you. So in family medicine, we still have a structured OSCE at the end of the 4 years. For us, once the WBA works well, we're probably going to get rid of the OSCE, but our written exams and our oral clinical decision-making exam will probably still stand. So there'll be 2 types of clinical competency committees. The first one is the local one. So you as WSU Emergency Medicine will set up your own local clinical competency committee. Every 6 months, you guys are going to sit with your registrars, and you're going to look at their portfolios and their EPAs and see where they're at and check how they're doing against those milestones. When they get to the end of the 4 years, you as a local committee will then decide, okay, great, I'm happy they've met level 4 and their 22 EPAs, they're ready to go and write their exams. And then that goes to a national clinical competency committee for emergency medicine, who will then look at all of the evidence that you're going to submit, and they're going to also agree. So it's no longer just an HOD that signs before they go and do their college exams. So this needs to happen and get signed off before they then write their final college exams. That was all the concepts. I've got a couple of slides on feedback. So as you can see, one of the biggest the thing that makes WBA work is the feedback that gets given with every single little bit of assessment. And we have a challenge with feedback culture in medicine worldwide. And in South Africa, I don't think that's also still an issue in some disciplines. I just want to give an idea of what 2 different cultures looks like. So the one is what I'm going to call the depreciative feedback culture. Versus an appreciative feedback culture, and it's quite clear which one we want to move towards. And what I mean with a depreciative feedback culture is the kind of culture where as seniors, we sort of go, no, but you should already know that. Why have you not learned that? A lot of the way we try and motivate them is through humiliating them and making them, make them look bad and hoping that's going to make them study. The surgical guys love the Navy SEAL imperative, throw them in the deep end and they must just swim because they have to learn to work under stress. We believe that people learn by us telling them stuff. There's a hierarchy. So you learn, the clever people teach the little ones down below the road. And this is very much also a fixed mindset, this idea that some people are good at stuff and some people are not good at stuff. And there's sort of this attitude that you already identify early on who you think is useless and who you think is excellent. So what we want to try and do is, this is of course quite a negative extreme picture, but I think we've all had experiences of that. But what we want to try and move it to is a consistent appreciative feedback culture where everybody feels within the department there's no such thing as a stupid question. We motivate people through affirming by what they're doing well and what they are achieving rather than through humiliation. You prepare before you scare them. So you make sure they've had their practice like we do with our ATLSs and ACLSs before we throw them into the deep end. We learn through reflection, and we expect that our own registrars will also learn by thinking about things. We can learn from everybody. We can learn from the nurse. We can learn from our juniors. We can learn from our colleagues. And having a growth mindset, everybody can learn to do something. It's just a matter of practicing and figuring out where your areas are that you need to improve. So this for me is not a difficult thing to teach in terms of the techniques of good feedback is actually very simple. Our challenge is we're actually trying to shift a paradigm because most of us have been trained in a depreciative feedback culture. And you will have doctors coming into your department that has this habit. This is how we talk to juniors. And how to change that paradigm is quite something. So we know that to have an effective feedback, we have to build relationships of trust. And you can't build trust until you have this appreciative feedback set. And so this is a skill that needs to be taught and needs to be integrated into their daily work. It needs to be part of the way that we work. So maybe I'll do my punt here. So what we've decided is we need a short course on WBA for clinical supervisors, which will be, it's probably going to be about 6 to 8 contact hours, but we're going to break it into modules. So we're able to do it, fit it into busy work schedules. It's going to be endorsed by the colleges. I've already written the brief for it. And then I'm presenting it to our departmental board meeting this Friday, and it will then go to faculty. And I want to run a pilot, and it can actually even be with any of you guys if you were keen, in October, which will run at WSU. Some of it will be online, some of it will be face-to-face. There's going to be role-playing and stuff in it. And that'll probably be between maybe 14 to 18 CPD points, with at least 4 ethics points in there as well. And then I'm presenting it hopefully at the CMSA Senate meeting, end of October, as a best practice, which we will then look at having available as at all the universities eventually, to be able to start massively training up clinical supervisors on WBA and feedback. So just in a summary, so like family medicine, you guys are going to finalize your EPAs. You are going to decide as WSU Emergency Medicine what EPA milestones needs to happen every year. You're going to choose a tool, and you're going to start doing WBAs in your departments. We're going to train up your supervisors on feedback. There will be some acceptability and feasibility focus groups, probably not this year, next year, to look at how you guys are doing. The colleges of medicine and SACOMT will oversee the implementation eventually of e-portfolios to make all our lives easier. You, as emergency medicine, will need to allocate your own local clinical competency committee, and then eventually your own college will have its own national clinical competency committee for when you guys finish their training. These are just all my millions of sources, but and I will send you these slides as well. Thank you very much, everybody. I would love to open this up to questions and discussions. And firstly, I'm very interested to hear just where you guys are at with WBA in your department at the moment. Thank you.